You're listening to Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is May 13, 2011, and I'm your host, Dr. Jay Portnoy. Our topic today, nasal provocation. Our presenter is Dr. Paul Dowling. He's the Allergy Immunology Program Director at Children's Mercy Hospitals and Clinics.
Okay, well, I'm going to talk today about nasal provocation. This is taken from a couple chapters from the last two editions of Middleton. One of the reasons that I ended up picking this topic is one that the fellows have to know about this, but also this is sort of near and dear to my heart in the sense that as I was a fellow, my research was in nasal challenges and nasal provocation, and I spent hours upon hours in the lab squirting allergens up people's noses and collecting mucus. So I'm going to share with you the wonders of nasal provocation, I guess.
Sounds delicious.
Okay. Yeah, especially before lunch. So I have no disclosures. Next slide. These are the pre-test questions. Nasal steroids need to be avoided for how long before provocation? 3 days, 7 days, 10 days, or 2 weeks? I'll let you put down the answer.
Okay.
Contraindications to doing nasal provocation are all but pregnancy, nasal surgery 12 weeks ago, history of anaphylaxis to agent to be used, episode of rhinitis in the last 2 to 4 weeks.
Okay.
And the third one, true statements about active posterior rhinomanometry include all but is not suitable for children, not suitable for patients who cannot tolerate close-fitting masks, records pressure, volume, and flow rates during tidal breathing, measures cross-sectional area of nasal cavity. Okay. And you can put down your answers, and we'll move to the next slide. Okay. Nasal challenges and nasal provocation testing, and I'll probably find myself saying nasal challenge more than the provocation because that's what I'm used to calling it. But it's unique in asthma and rhinitis because their symptoms and signs can be reproduced in a lab under controlled conditions. And you can take agents like pollens that you think may be triggering symptoms and challenge people with those just like you do with bronchial provocations. The thing about the nose is that you're less likely to have severe reactions, and it's very accessible. Next slide. As stated, it involves the administration of suspected allergens, and also it's been used to try to identify the role of mediators that are thought to be involved in allergic disease, and also in checking for the response of drugs and blocking reactions to allergic disease. And so it's been used for a long time to study allergic and non-allergic rhinitis. It's also been crucial for the investigation of the pathophysiology, immunology, and pharmacotherapy of rhinitis. When I was a fellow many years ago, one of the leading allergy areas of research at the time was early and late phase reactions, and there was a lot of stuff that we learned about on the nose and allergic rhinitis from people like Dr. Niclario, who originally was at Hopkins, and I believe now is at the University of Chicago. But he's an ENT person who worked with the allergy immunology group there and did loads of studies looking at all the different aspects of nasal physiology, cell types, and perfected some of these provocation methods, at least in their labs. And if you go through the literature, you'll see paper after paper with Dr. Niclario and his associates that had done a lot of these studies. A lot of the stuff that we know about allergic rhinitis and mechanisms is from his work. The nasal provocation also mimics naturally occurring disease as best you can in a laboratory setting. And it's thought that it may even be, if you are a believer in the one airway theory, that by doing some nasal challenges, you may also get some information about bronchial hyperactivity as well. Next slide. There are limitations, and part of it is there's a whole variety of methods that have been used, and we'll go through some of the more common ones. They have been shown in different laboratories, like the people like Dr. Niclario, when they had a method and they were using it repetitively, they had pretty good reliability and reproducibility. However, there was differences between different labs. They used different ways of providing the allergen to the nose, different techniques, different scales of measuring results, different scales of measuring endpoints, and we'll talk about all this stuff. And then on top of it, as you know, not every allergen is standardized, and so there are a variety of different units for the allergens, and this even gets more complicated if you deal with some of the units that they use in Europe. Next slide. The benefits, as I said earlier, there's we can learn certainly about the physiologic changes, the mediators, the cytokines and cells that are involved in reactions. This has helped us understand the events that occur after nasal provocation to a variety of stimulants, and we'll talk about a variety of these later. And it's important to note that a lot of the medications that we use for allergic rhinitis have become on the market as a result of some of the trials that were done with nasal provocation in testing some of these drugs. And this also allowed us to do some comparisons between different treatment strategies. Next slide. For the most part, nasal provocation has been done more for scientific investigation. However, in some countries, nasal provocation is used for clinical evaluation. I'm not sure how much it's used anymore here with ENT doctors, but I know probably 10, 15 years ago there were a fair number of rhinomanometers that were being employed in ENT offices that they were using to measure response to allergens and other factors. In Europe, when I think I've talked about this with the fellows before, probably about 8 years ago, I went to the academy to a workshop on nasal provocation. I thought I would kind of update myself on that since I had done research on it, hadn't really been involved in it for a long time. The workshop I went to was basically, I think 95% of the people in there were Europeans, and they were, when we talked about immunotherapy, they were sort of appalled that in the United States we're using multiple allergens, where in Europe they're more likely to use 1 or 2 allergens for immunotherapy. And what the gist of this was is that basically if you did skin testing to someone to get a better idea if that's sensitization versus clinical symptoms, they would do skin testing on a patient, and the skin test that had the biggest reactions and the history that sounded most likely to be positive, those are the ones that they would do nasal challenges to, and the allergen the patient had the biggest reaction to on nasal challenge would be the one they'd be preferentially put in the immunotherapy. So they may be just on one allergen, and it would be based on nasal provocation testing. Here in the United States, it's not used widely for day-to-day management, but again, in large part because we're more likely to rely on medical history, skin test, specific IgE, and we're more likely to use a mixture of extracts. Next slide. So again, indications for nasal provocation to assess the role of allergen when skin and blood tests are negative. So if you have someone that is determined they're allergic to cat or dog or whatever the pollen is, and skin testing or blood tests are negative, if you wanted to pursue that, theoretically you could do a nasal challenge. Again, to confirm the clinical relevance of a specific allergen, like I had talked about with Europeans, to confirm the role of a specific occupational agent in causing rhinitis. So this has been used also in occupational medicine, where people have had problems with things they've been exposed to at work and causing nasal symptoms. And also to identify a role for a non-standardized or novel allergen that you make a preparation and do some studies with. Next slide. Further, you can, if you do nasal challenges, you can also induce symptoms with other. You can see if you can induce symptoms in other organs, and look at the conjunctiva, middle ear, sinuses, lower airways. So, for example, if you thought there was a relationship between exposure to cats and someone having increasing risk of middle ear infections, theoretically you could do a nasal challenge and look at tympanometry, I guess, along with that, and see if you could identify changes and that sort of thing, or in conjunctival symptoms, etc. You can also use it to confirm the role of allergen in asthmatic patients when bronchial challenges may not be safe. Again, some people use it to determine nasal reactivity before starting immunotherapy, and there's been some use of it afterwards to assess how effective the immunotherapy has been. Next slide. So again, you can look at a whole variety of physiologic measures. You can look at cell types, mediators that go on in all these different allergic responses. And again, it can be used to check the therapeutic effect of drugs. So if you had a new nasal spray that you think is going to be the best thing for allergen, for allergic rhinitis, and you did a study with it, and you did nasal challenges to people that were allergic to trees, had positive reactions to trees, then treat them with placebo or with the active drug, brought them back to another nasal challenge, and see what the response would be and see how clinically effective it would be. Sort of what's been done with asthma medicines historically with bronchial challenges when doing studies and for efficacy on asthma medicines. Next slide. The other benefit is that nasal challenge can be done unilateral, bilateral. So if you're looking at contralateral responses or nasal responses, you can do that. So again, you can get as involved as you want in some of this. So you look for vascular responses, neural responses, ipsilateral, contralateral responses. Next slide. The thing for the fellows is that they should understand the term late phase reactions or response. We don't seem to talk about that very much. There was a period of time where we were always talking about early and late phase responses in asthma and allergic rhinitis. That was probably 10 years ago or longer, and everything was related, and we looked at cell types and early and late phase responses, and et cetera, et cetera, et cetera. As you can see here, Dr. Blackley, back in 1873, first coined that term, and this is the spontaneous recurrence of a late nasal response after initial allergen challenge without further provocation. So you have a response, you seem to get better, and then later on you have symptoms again. For the fellows, they see that in their asthmatic patients. We see it in patients who get allergy injections at times, but it also occurs in our allergic rhinitis patients. They're not likely to be going to the hospital for that, as you would with asthma, but it occurs. And as you can see, depending on the study, 5 to 50% of patients will have late phase reactions with allergen exposure. The late phase response to the nose are more difficult to quantify and usually manifest as nasal obstruction, and people are notoriously bad at trying to identify or quantitate their own nasal obstruction. That's one of the reasons they do some of these testing we're going to talk about here in a few minutes. But the other thing to remember is that late phase reactions are more likely to mimic what you have when you have chronic disease. So if you have in allergic rhinitis, the biggest late phase reaction is going to be nasal obstruction. And for people that have allergic rhinitis to, let's say, tree pollen, that just went through tree pollen season, the late phase reaction is more likely what those people are going to have every day while they're in tree pollen season, if they're allergic to tree pollens. Next slide. Again, there's a whole variety of cytokines and mediators that have been used for provocation. In the interest of time, we won't go through that. I'll mention some later when we go to the next slide. There are some contraindications for doing nasal challenges because symptoms and pathophysiologic changes can occur with a recent episode of allergic rhinitis, and they tend to persist. That you wouldn't do it if you wouldn't do it in the height of someone's pollen season, and part of that is also that if they have recently had allergy symptoms and you were to give them some allergen in a nasal challenge format, you can have a priming effect. And does any of the fellows know what priming effect is?
Like once you have an initial exposure, you're more apt to develop the reaction a little bit quicker, a little bit more severely on repeat exposure, right?
Yeah, and it usually occurs with less exposure. I mean, less amount will cause you to have significant symptoms. And that's very common in people that have seasonal allergies. And so again, if you have someone who's already sick, you don't want to provoke that and make things worse for them. And if you've had someone who's had some bronchial issue or like an asthma attack or something, you wouldn't want to be doing that at the time they're getting over that. Next slide. So these are some of the contraindications listed here. Episode of rhinitis in the last 2 to 4 weeks, so you have significant symptoms. That you're in an exacerbation of allergic disease, so you're in a pollen season, let's say, and you're allergic to those pollens and you're having symptoms every day. Use of allergens known to have caused an anaphylactic reaction. So if you're highly allergic to cats and every time you get around cats you've had anaphylaxis, you won't be wanting to do that. If someone's pregnant, just because you don't want to risk them having some significant allergic reaction while they're pregnant. Nasal surgery in the last 6 to 8 weeks. Coexisting severe general disease like cardiopulmonary disease, and treatment with certain medications, and we'll list these medications in I think it's the upcoming slide here. Next slide. There are recommended periods of withdrawal for medications. The thing that you need to realize is when you do nasal provocation, if you're going to look at nasal patency, symptom scores, and if you're going to collect mucus for mediators and cell types and stuff, you can't do that all on the same day. They have to be done at least 2 visits. Part of that is because to be able to collect the nasal secretions, you have to put lavage fluid into the nose and manipulate the nose, and that can actually affect the airflow of the nose itself if you're measuring airflow and nasal flow and patency and such. So to increase the amount of lavage fluid that you get back when you give them the lavage fluid, usually what is done is the patients are pre-treated with a topical vasodilator in the nose, such as neosynephrine, and that basically opens the nose further so you're able to get this lavage fluid in and get it out. And so that can affect also the readings of if you're trying to do all that on the same day, so that's why you can't. So that's common for that, and one of the days if you're going to do collecting fluid is to pre-treat with the topical nasal decongestant. There are other medicines that they don't know how much effect they may have, like contraceptives, eye drops, preservatives. And then the other thing that can play a role in some of these outcome measures have to do if you have polyps, atrophic rhinitis, and a deviated septum can all play a role in altering some of the values and making it more difficult to get a true reading on what's going on. Next slide. Okay, so these are some of the common medications and the time that they suggest withdrawal from these. So antihistamines, depending on the antihistamine, short-acting antihistamines 3 days, the longer-actings a week, nasal antihistamines 3 days, nasal steroid 3 days, oral steroids a week, and leukotriene antagonists for a week. And you can see the others there. Next slide. There are different nasal provocation models. And we're going to talk about these briefly, each one. And I'm sorry we're doing this just before lunch, but I guess sometimes you have to do it. The next slide. The nasal lavage method, this is a method that I used when I was a fellow, and it's commonly used because it's probably one of the easiest to do. You're able to you basically do this to collect secretions, and also from those secretions and lavage fluid, you can also look at cell types and analyze mediators if you're trying to do this for scientific purposes. It's also provides a readily accessible material for studying pathologic responses in the nose. And basically what you do is you basically put fluid in the nose, and you have them hold it and then expel it into a pan, which doesn't sound too good right now, but that's what you do. As I said earlier, usually the patient, when they're doing this, they've come in and they've gotten acclimated to the room in which they're doing the nasal challenge, so their nose is in tune with the room that they're doing it in. There's not any differences between being outside if it was in the wintertime and coming in from the cold and having some changes in their nose because of that. But basically, they're pre-treated with a topical vasodilator, and they tilt their head back, and basically you put in between 1/2 and 1 teaspoon of this saline solution. And it's basically warm to room temperature, and you tilt your head back. They try not to swallow, and they basically hold it there for 10 seconds, and then they lean forward and expel it into a pan, like one of those kidney pans or whatever from the hospital, but basically into some kind of dish that you can then collect that and try to isolate your mediators and your cells, etc., by whatever protocol you're using. Okay, next slide. So this allows you samples from the nasal and nasopharyngeal airways. The advantage is that it's easy, is the ease of the challenge in the collection of secretions. You can get a large amount of recovered lavages, and it allows for the simultaneous measurement of several mediators and evaluation of cells all at the same time. The disadvantage is that you have to pre-medicate, so you're not going to be able to do like nasal flow studies and such on those days, or looking at symptomatology per se on those days. You also get because you're doing both nasal cavity and nasal pharynx simultaneously, it doesn't allow you the investigation of nasal reflexes very well. Next slide. The aspiration nasal lavage method is a combination. It's pretty much the same, except what they do is they put a soft catheter into the floor of the nose, and they squirt the lavage fluid in, and then they suck it out with the aspiration device. So the advantages are pretty much the same as the nasal lavage. You can instead of having them expel both simultaneously like the traditional nasal lavage do, you can suck it out of each nose separately and separate those if that was important to you. And again, because you have to pre-treat, you can't check nasal resistance when you're doing that. So that'd be for another day. Next slide. The nasal pool device, which I've never used, is basically a plastic container that fits snugly to your nose, and you basically squeeze it with the solution in there, and then you basically squeeze it, suck it back, so sort of like, in a sense, like a ball syringe sort of effect. And it has the advantage of delivering a known concentration of allergen to one nasal cavity. So, next slide. And the last method I'm going to talk about is the filter paper disc method, and I have a picture here in a minute. But basically what they do is they have these little tiny filter papers that have allergen on them. They put them on the septal wall, and they put a disc on, leave it there for about a minute, and then about, I think it's like a minute later, 15 minutes later, they start they put a dry filter paper on that has nothing on it, and they put it in the nose on the septum, and then they start collecting secretions on that dried filter paper. You can't look at cells with this, but you can obtain mediators from this. But you can, again, it's less cumbersome and not so invasive, and patients are more likely to tolerate this. Next slide. And here's an example. So they have whatever the challenge is on the mucosa for a minute, and then they start collecting. They'll do, depending how many challenges or how many steps of the challenge you're going to take, they would have repeated collections that they would do. Okay. A nice picture of the nose for today. Okay, next slide. This all gives, these next two slides are all busy on this. The important thing about these slides, or about this, is that basically with any time you're going to do any kind of challenge techniques, be it nasal or bronchial challenges, before you do all this stuff, you've gotten a good history, physical, you've done testing, skin testing, you have an indication for doing this challenge. This isn't something you just do on a lark. And that basically the people that do these are people that have experience with this, know what to expect, know how to deal with the unexpected circumstances, and that you do this in a, you have a protocol, you follow the protocol, you do it in standard conditions. It's also, because there are circadian rhythms to the nose, and the nasal resistance and airflow changes between each side of the nose constantly during the day, and is also affected by the time of day. It's also affected by your exposures during the day, if you have any noxious stimuli, if you've been exercising, etc. So usually most people recommend, if you're going to do these, you do them first thing in the morning before the patient's had a lot of exposures to these things. As you can see, things, even diet, fumes, cold air, and exercise can have affect the results of the nasal challenge. And again, as I mentioned before, you want them to come into the lab and to be sitting there for at least 20 minutes to a half hour, basically, so their nose can kind of equilibrate to the surroundings. And usually, because you're going to, if you're doing this for scientific purposes, usually you're looking at collecting secretions for mediators and looking at different cell types. So you're going to end up doing 2 separate days because you're going to probably be pre-treating with a topical decongestant. Next slide. These challenges, as I said before, can be unilateral or bilateral, depending on what your purpose of doing the study is. Basically, when you do this, there's a baseline that's you look at, so you'll do a diluent challenge, and then if that hasn't really changed much as far as symptoms or nasal flow, then you'll advance on to doing the challenge with the allergen, and these are usually at 15-minute intervals, and they usually have a 3-fold increase in the concentration of the allergen that's used. Doses are increased until a positive response is obtained or to the maximum concentration is reached. And unlike methylcholine challenges, where we have pretty good standardized therapies and endpoints, in bronchial provocation, in nasal provocation, there really aren't. And so there's, I'm going to show here in a minute, there have been different people have used different endpoints, and I think the biggest thing is that when you're doing these, that you're consistent with the way that you're doing it, whichever one you pick. Next slide. Basically what you do with nasal challenges is similar to what you do with bronchial challenges. The patient is skin tested, and you do serial dilutions of allergen to find out at what point the patient would first have a reaction to the allergen. What they often do, they'll take these dilutions, and they usually start at 1 to 10,000 or 1 to 5,000 weight per volume. The 1 to 10,000 weight per volume for the fellows would be equivalent to what we have on our skin testing of 1 to 100, if I did my calculations right. What we have on our immunotherapy that we use for allergens would be equivalent to the 1 to 100 concentration. But basically you do serial dilutions with the allergen, and basically you work backwards from where they have a reaction. If they haven't had a reaction, if the skin test was negative and you're trying to do this because they think they have symptoms, but the skin test and blood tests were negative, then you can start at that 1 to 10,000 or 1 to 5,000 weight per volume, or whatever allergen using the equivalent, and then do serial dilutions that are more concentrated from there, looking at responses. For someone who has a reaction on skin testing, then you would go to the point where you have a 3 millimeter wheel would be your starting point. So whatever the allergen, so you do some serial skin tests with your allergen extracts, and